Hello everyone and welcome to my channel. Today we are diving into an important cardiovascular topic, deep vein thrombosis or DVT, a condition that affects millions worldwide and can lead to life-threatening complications, include pulmonary embolism. We will go through pathophysiology, risk factors, clinical assessment, diagnostic, treatment, and prevention. So let's get started. So what is DVT? DVT refers to the formation of a blood clot within the deep venous system, most commonly in the lower extremities such as the femoral, popliteal, or iliac veins. Now let's talk about the pathophysiology. Virchow's Triad refers to the three major mechanisms contributes to the development of thrombosis, which consist of number one, venous stasis. The slow flow of blood leads to platelets start sticking together and the clotting factors accumulate and leads to thrombus formation. This will happen in many situations like immobility, paralysis, long surgeries, etc. Second one is endothelial injury, which is damage to the vessel wall, exposes the subendothelial tissue and promotes platelet adhesions and activation of coagulation cascade, like in case of trauma, surgery, or central venous catheter. The third one is hypercoagulability, which can be due to genetic factors like factor V Leiden or secondary to malignancy, pregnancy, or hormonal therapy. Now we will talk about the types of DVT, which depends on where is the thrombus exactly. So it can be proximal when the clot involves the femoral or iliac veins, and this carries a higher risk for pulmonary embolism. Or it can be a distal DVT when the clot involves the calf veins, but unfortunately it can also propagate to proximal DVT. Regarding the risk factors, it can be divided whether it's a major risk factor or moderate or minor risk factor. In the case of major, it can be secondary to recent surgery, especially orthopedic surgeries, major trauma, active cancer, prolonged immobilization or hospitalization, previous DVT or PE, pregnancy and postpartum state, oral contraceptives or hormonal replacement therapy, obesity, thrombophilia, like factor V Leiden, protein C, S deficiency, or antiphospholipid syndrome. Regarding the moderate or minor factors, it can be secondary to increasing age, smoking, long flights, or even varicose veins. As we said before, DVT is very serious if undiagnosed. So let us dig into the clinical presentation. The patient can present with unilateral swelling, pain or tenderness, warmth, redness or discoloration of the affected limb, and heaviness of the limb. So when the patient presented with these clinical features, the first thing is to measure the calf circumference, and should be measured 10 centimeters below tibial tuberosity, expecting the difference more than 3 centimeters between the suspected limb and the normal limb. Also, there will be pitting edema, tenderness along deep veins, and the last thing, which is the Hommel sign, but now not reliable and is no longer routinely recommended because it may lead to thrombus dislodge. And this carried when we flex the knee joint, and the patient will experience pain in the calf muscle. Now let's talk about the Wells score, which is used to estimate the pre-test probability in patients with suspected disease. and it is the initial step in the diagnostic workup. This score will stratify the patients into likely or unlikely the patient have DVT, and then it will guide us to further diagnostic testing. So each feature in this Wells score, it will carry 1 point, like active cancer, treatment ongoing within 6 months, or palliative treatment in case of paralysis or paresthesis, in also recently bedridden for more than 3 days, if the patient has localized tenderness along the distribution of deep venous system, if there is calf swelling more than 3 centimeters, if there is pitting edema or lateral superficial veins, previous documented DVT, all of these will carry a positive point. But if there is another alternative diagnosis to DVT, we will subtract 2 points. Let us talk about the interpretation. The interpretation will be whether there is high probability, moderate probability, or low probability. And if the patient is unlikely to have DVT, then we will proceed with D-dimer. If it is negative, then safely we can rule out DVT. But if it's positive, we have to proceed to ultrasound. In case likely the patient have DVT, then we will confirm this by ultrasound. If positive, we will proceed to treatment. If negative and the symptoms persist, we will repeat the ultrasound in 5 to 7 days period. We have to consider that regarding D-dimer, it is highly sensitivity, but it has low specificity, as many false positive results can occur, and this can be encountered in case of infection, pregnancy, cancer, or even recent surgery. Now let's talk about the most important part, which is the treatment. And let's start with the anticoagulation, which is the cornerstone of the treatment. The first line option in case of anticoagulation is the DOAC, the direct oral anticoagulant, which consists of apixaban, rivaroxaban, edoxaban, dabigatran, and this preferred for patients unless contraindicated. The second one of anticoagulant is the heparin-based therapies like low molecular weight heparin and fractionated heparin, and this is referred or preferred in case of cancer-associated thrombosis or DVT during pregnancy. The third one is warfarin, and this is used if DOACs contraindicated, but we have to put in our mind that it requires INR monitoring. Now we will talk about the duration of therapy, and this depends on the cause and how high the risk of recurrence, and we have to evaluate the risk of bleeding versus benefit. So according to the cause of DVT, it can be provoked if there is clear temporary risk factor like pregnancy, immobilization, trauma. In this case, the duration of treatment will be 3 months. If unprovoked or no identifiable trigger, 3 months. If cancer associated, 3 to 6 months. Then continued as long as the cancer is active. In case of recurrent DVT, indefinite duration of time for treatment. DVT with high bleeding risk, shorter duration even if unprovoked. DVT in pregnancy, the treatment will continue throughout pregnancy plus 6 weeks postpartum. Another modalities of treatment is the inferior vena cava filters, and this is indicated only for absolute contraindication to anticoagulant in case of recurrent pulmonary embolism despite adequate anticoagulation. And the last modality of treatment is the thrombolysis or thrombectomy, and this is reserved for massive iliofemoral DVT.
Also, it can be used in limb-threatening conditions, which is the blue limb, and in selected patients which they carry low risk of bleeding.
So regarding the complications, the most serious one, as we discussed before, is pulmonary embolism, because it's fatal if undiagnosed early and treated properly. The second one is post-thrombotic syndrome, and this is caused by venous hypertension, and the symptoms will be chronic swelling, pain, varicose veins, and venous ulcers. This complication can be prevented by compression stockings that may help reduce symptoms but are not reliably preventive. If you found this video helpful, don't forget to like, subscribe, and share with colleagues. Thank you for watching, and stay clinically sharp.